Good morning. My name is Michelle Lavelle Henry, a member of the Social Justice Ministry team. We build social justice forums around a common theme. And this program year, our theme is invested in each other's futures. Through these forums, we aim to learn about opportunities to engage and action for Westminster members to ensure all of our neighbors thrive, to better understand the structure and systems that have failed many of our neighbors, and to explore ways we can work together to build better outcomes. To respond to Krista Tippett's charge from our opening forum, who will we be for each other? Today, we welcome Ellie Garrett, Program Manager for Population Health Innovations at the Minnesota Department of Human Services. Ellie taught health policy at St. Catherine's University for 15 years and is past president of the Minnesota Public Health Association. Ellie and her team work to reduce disparities in birth outcomes using a community design model with culturally specific care and social support. Ellie's presentation this morning is on social drivers of health moving to action. She will address renewing our understanding of how inequitable social conditions impact health and naming ways we can move from knowledge to action. But before we begin, those attending in person in the Meisel room, raise your hands and we'll bring a microphone to you when you have questions, including those on the live stream. You can be heard with your questions or comments. For those attending on the live stream, please submit your comments in the chat, and I will be able to get your questions or concerns answered. We will also be hopefully have time to do a group, like small group sessions, so that we can kind of brainstorm as a group to come up with action items or ways in which social structures have failed our community. Please welcome Ellie Garrett.
Pardon me. Hi, everybody. I am just delighted to be here and to see new friends and old friends here in the room, including a college roommate and a colleague of some, probably, how far do we go back? 30 years? I don't know. Look at the color of my hair. So anyway, I'm just delighted to be in what I already know is a very warm and welcoming room. I'm going to start out by asking if there are any other fans of the NPR program, Wait, Don't Tell Me, here. Okay, not surprising. We're the demographic, right? Okay. So when they get to the segment that is about Not My Job, you can always tell the folks who actually listen to the show, the celebrities and authors and other folks who are invited to come and then asked goofy questions about something they have no knowledge about whatsoever, right? And any ideas about what it is that gives them away as being either well-coached or experienced listeners of the program, or just folks who are sort of able to read a room if you're in person, is that they always ask the audience, okay? They ask the audience, and the audience always gets it right. I am astonished at that. These are the craziest questions, and about the weirdest things that were in the news now or 40 years ago. And the audience seems to always know. And then the celebrity or the guest or whomever wins, and somebody gets the voices of Peter Sagal or whomever on their email or their voicemail. So what that illustrates is the wisdom of the crowd. I am completely confident that while none of us individually are experts on the topic that we're going to talk about today, including me, I still have a long learning journey ahead of me, and one that I hope to continue on throughout my life and past retirement. While none of us are necessarily experts at all the things we're going to be talking about individually, collectively, both here and in this room, as well as online, we have an amazing source of knowledge and much more than I can offer. So with that in mind, I'm committed to keeping this very interactive. I want this to be a conversation among us here in this room as well as online. I want people to learn from each other, and I will mainly be a facilitator, mainly be somebody to help us along on the conversational journey where we'll have, hopefully, a few aha moments, or maybe just reminders about, yeah, I know that, I should have known that. So maybe that'll happen too. And hopefully it won't be boring, and hopefully it won't be too 101-ish. There are people in this room I know who could talk so eloquently about this topic, much more eloquently than I. So I bring some humility to the conversation that we're going to have. So we're here today to just kind of refresh our knowledge about social drivers of health. And I use that phrase intentionally. The phrase is also called social determinants of health. That may be more familiar. How many of you have heard about social determinants of health? Okay, seeing some heads nod. Oh, and thank you, by the way, for not all sitting in the back row. Appreciate it. But now, increasingly, we're starting to hear social drivers of health. Does it create a kind of a different connotation for you? In what way? Yes?
There's something fateful about social determinants, and social drivers seem to invite us into the act.
Exactly. That's exactly it. So I'll repeat it for the benefit of those who are, no, that's okay. We're online, so I'm going to repeat that. So there's something fateful about the word about the phrase social determinants. It feels like it's done. Feels like we can't impact it. But social drivers of health invites us into the conversation. It's also something you can steer, right? You can change direction, and you can put on brakes, and you can impact it. As a driver, you can either be one of those folks in the passenger seat who is helping the driver. So it invites more activity and discourages a fatalistic attitude toward what are really intransigent issues in our society. So today I'll be talking about social drivers. If you refer to social determinants, that's okay, but I would urge you to start getting used to this other phrase, if you're not already, that kind of gets you in that frame. So the first half of today, I want to talk about just renewing our understanding of what those social drivers are. And to make it a little more specific, let's think about it in terms of COVID. It's on all of our minds all the time. We've got masks in the room. I'm keeping socially distant because I have a wedding coming up, and I cannot wait. It's not mine. It's the first one in the next generation, and we're all very excited about it. So, and I understand that you even have some juggling of staff today due to COVID. So, what are some of the drivers of health? And those of you who are online, please start adding things into the chat. And those of you who are in the room, I'll start circulating a mic, or you can, however we want to do this. And what are some of the social drivers that impact how people respond to COVID?
Or they can just say it, and I can write them down too, whatever
Yeah.
works.
Some people are claiming crazily that this is a political thing.
Say more.
Oh no, I mean we're picking on the Republicans. I'll pick on them because they didn't see it as. I guess they must have seen it as being true, but they thought it was against one political party, which is shocking to hear. But
So the partisan nature of our response to COVID is itself something that impacts how we as a society and also how individuals respond to the disease. Let me back up a second and say this is a condition, and I would imagine everybody in this room knows this, but there are extraordinary disparities in how COVID affects different groups of people. And interestingly, those disparities exist both in the prevalence of the disease and exposure to the disease. So just whether or not it's around you and whether or not you're going to be more likely to catch it. And then also, it impacts how severe the condition is. BIPOC populations, Black, Indigenous, and people of color, both significantly more likely to be exposed to and catch COVID, also significantly more likely to have the crueler forms of the disease that ends up in hospitalization and ends up in death. So just like other health conditions, COVID has those disparities in it. So what are some of the conditions in our society that might make it more likely that people of color, Black and Indigenous people, catch COVID more often?
Access to stable housing, having reliable, affordable places to live, not being constantly on the move, is one of the things that affects access to healthcare in general, and then access to practices, both personal and professional, that make a difference in health outcomes.
So stability of housing, let's explore that even a little more. What else about housing might impact somebody's likelihood of catching COVID?
Well, I think proximity or communal housing, when you're not able to necessarily separate from ones who have been exposed or sick, you're more prone to get it yourself.
Absolutely. So how crowded the housing is. And it can be crowded in a good way. Don't we all envy the social cohesion and family cohesion of multiple generations being so close that they are each other's neighbors? They may even be each other's roommates. But if that's happening in a house that's small by the standards of those who are in this room, then that also means more exposure. Yeah, and more difficulty to isolate. How about people who are unhoused? How might being homeless impact the likelihood of catching COVID?
Well, prior to COVID, I think there was a great emphasis on shelters that put people in very close proximity to one another. During COVID, I think one of the drivers that was recognized that was not good for COVID, and more people were helped to get like motel rooms or temporary living situations that weren't like right next to each other.
Right. Something the agency that I worked for got dinged on was administering some of the federal money for housing assistance for homeless people at the very beginning of the emergency. But what they were dinged on was paperwork. And not to disparage the importance of really fine record keeping. I do not. I want a good audit trail. But when one is in the midst of an emergency, the agency that I work for chose rather deliberately to prioritize getting people into that housing situation rather than some of the ordinary bureaucracy. that we too had to figure out how to be different, right? And that was clunky. So getting people into non-congregate emergency housing situations, which may or may not still be available today, despite the extraordinary contagion that COVID remains. So let's think about something other than housing. Give me another social driver. Hang on, wait for the mic.
Geography.
Say more.
If you find yourself coming down with COVID in Whittier, Alaska, you have to be on a train for 3 hours to see any doctor.
How about if you are without a car and you know you've been exposed and it's the early part of the pandemic and there are only 3 places in the city where you can go and get tested at the beginning? Prospect of taking, 3, 4 bus transfers to get there? Your whole day, meanwhile, you're sitting on a bus with other people. So, Whittier, Alaska, greater Minnesota, but also the urban core of the Twin Cities. How about employment?
Well, employment, depending upon if you had the privilege of being able to work from home, do you have the privilege to take time off of work, or are you paycheck to paycheck and multiple jobs and commuting on your 3 transfers to all your different jobs? And so those kinds of, it's just sort of community realities.
How about whether or not you have sick time? And you haven't even been exposed to COVID, but you work in a place that does not pay you for sick time or allow you to take that unplanned time off. What is that going to do in terms of the likelihood of you catching it? Say something. What words? Not just head.
Yes, it certainly increases your likelihood, and I think it also, the advice for people to quarantine even if they weren't infected, the ability to follow those directions that might protect yourself and others is really diminished if you are also balancing your economic well-being.
Absolutely. So,
Yeah, so depending on your workplace, you might be more likely to get it, and you might be more likely to give it to others. And it also depends on whether or not your employment offers access to health insurance, and whether or not you are able to afford to go see a physician or go to the clinic.
so I mentioned spot on, everybody. I mentioned that I work for state government, the Department of Human Services, that administers Medicaid, health care for people who are poor, health care for people who have disabilities. Those are kind of that's core to the health care portion of the work that we do. And a lot of people who are working for a living receive services from my agency, receive their medical care, either from Minnesota Care or from the basic Medicaid program, also known as medical assistance. So let's think about education. We know that there are tremendous imbalances and disparities in all kinds of educational outcomes, right? I think everybody in this room likely knows that. How does that tie to COVID? How does that tie to health in general and COVID specifically? Was that a hand raise?
Sure.
Okay, go for it.
Well, our strategies for education changed dramatically during COVID, and that required internet access. It required some adults who could hang around kids at a home or community environment to help them continue to learn. And so we've seen that didn't exist in lots of cases, and kids are way behind as a result of that. Now, That's not really a driver of what happened, but that's a consequence of what happened.
Might there be some secondary impact of educational differences that also impact our actual health, our experiences of health that come from these educational disparities? How about, just think about the complexity of the conversations that we were listening to when Dr. Fauci was talking to us, when we were hearing complicated and at times contradictory information about individual health and about public health. Now, how many of you in this room struggled with that a little bit? Okay. And yet, I suspect we are all relatively well educated and have some basic training in how to work through that analytical problem that is COVID and think about it, right? Do you think that made it easier for you at all to think through that stuff and to respond to it? Sure. Now let's compound who the messengers are during COVID. The people talking about COVID who were carrying messages that, let's not even talk about the partisanship right now. Let's set that aside. Let's talk about messages that are credible, messages that are science-based. Who were the messengers?
I spent a lot of time trying to navigate the Minnesota Department of Health website to just understand, what I was supposed to do and what the critical determinants were of when I was supposed to do something or not do something. And that's because I had access to the internet and I knew how to navigate a complex website and I knew a little bit about how to read epidemiological data. And I think that's not assumed for a lot of populations.
Yeah, so even trusted websites are complicated. I can tell you right now, we don't have the most robust communications staff sitting around working for the state of Minnesota in all of our activities. We don't have the same kind of communications expertise that Google and Best Buy and 3M and all of those other companies have, right? So we have clunky websites.
Predominantly the people, because of our ongoing disparities, predominantly the people that are in the front and tend to be white and male. And so if you're from a different background, that's not exactly the trusted voice. If English isn't your first language, not your trusted voice. And I'll even say we lived in London during the pandemic, and it was the same over there, right? You tend to have years of that building up.
Yeah. So white and male, white and male, we've got, there are also voices from government itself, right? The Minnesota Department of Health, CDC, government agencies, right? Uniformly trusted, uniformly good relationships with all aspects of society. Anybody else? Okay.
I know that vaccine hesitancy was a real issue for a number of BIPOC communities, in part because they had good reason to be suspicious of government efforts to make recommendations or offer them some kind of medical treatment, because in the past the government had done that and it had harmed them. So there was a lot of hesitancy and lack of trust, understandably, about government efforts to encourage vaccination.
Sure. But government, fortunately, that's not the only messenger. That's not the only one. It's coming from healthcare professionals and healthcare institutions. Again, same kind of experience. Do we all enjoy the same relationship with trusted healthcare providers? So our main messengers, they're predominantly white men, sometimes white women. We are our Commissioner of Health. And our then Director of Infectious Disease and Epi over at the Department of Health, another white woman. So, but white people. And from government and from healthcare. And all three of those groups are not uniformly trusted, and for very good reasons. So we have knowledge gaps, we have housing gaps, yes.
Well, I was going to say that we may or may not, we, the middle class here, may or may not trust some of these groups, but generally, my feeling was, oh, we have enough insight, enough background, maybe we really should get vaccinated. Okay, so then we end up going to meetings, not this one, but other meetings where there's a lot of non-middle class, let's say, people there, and so then, I don't know if this is quite what you're getting at, but then we have to be, okay, we're vaccinated, but a lot of these people we're mixing with in this big group, they didn't get vaccinated. And I don't know if that's a wrong and deception, but I think a lot of the middle class, I don't know about all those people that didn't get vaccinated, but generally, regardless of what they heard, thought vaccination to be a good thing. I mean, I grew up during the polio epidemic, and I knew about vaccinations from years and years ago. That's my view.
I think there we get into some of the partisan differences too. There were very partisan perceptions that occurred around the trustworthiness of information and of science.
I guess I feel, or we maybe feel as middle class, a lot of people didn't get that information. I got it, I may or may not have agreed with it, but a lot of people didn't get it. And if I've had meetings with people like that, then you're going to be possible get it yourself.
Yep, so we have different degrees of exposure just based on who our friends and colleagues are and whether or not, how seriously they're taking the social distance and vaccination requirements. How about online? Let's see over here what some of the, what's coming out here. So we got a lot. How about anything coming through on the chat that would be different than what we're talking about here?
No.
Not yet?
I think we have 5 good points, and sometimes there's a trifecta of all of these, is what I was thinking.
Yeah.
Not that I should be facilitating,
Yeah.
not giving answers,
Yeah.
but what I kept bubbling up was, so you have, poor health conditions because you don't have access to health care or lack of insurance. You have less education, so you don't understand what's happening. And then you kind of have no insurance. So I think of that as a kind of this trifecta of why this disparity exists.
Yeah.
And I think these are really good 5 bullet points, and then I think right now you probably would like to move into kind of action, maybe?
I'm going to go for at least one more issue before we move into action. And I want to talk about institutional racism. But before we do that, I've got a comment from back here.
I think there are also structural issues from a policy standpoint, which, and specifically I'd say, as a country, we prioritize private insurance, private health care versus public health. Our commitment to public health is woeful.
Hang on to that for the conversation about action items. Couldn't agree with you more. So, institutional racism. Now, we know that institutional racism is actually a contributor to all of the disparities that we've already talked about. But institutional racism is also an independent factor when it comes to health. So how might racism, institutionalized racism, that buzz that many people who identify as BIPOC live with on a daily basis, how does that impact their response to COVID? Any ideas? What I have in mind is a fairly technical answer, and I do want to get on to the next part. But does anybody have any ideas? Have any of you heard about a cortisol response? Any healthcare providers or folks been? So I've got some nods about cortisol. So cortisol is a stress hormone. It gets released about the same time as adrenaline gets released. And when you live with the chronic stress that is the racism in our society, it changes your stress response. How does it do? So I'm getting heads nodded. Would you like to explain how that works?
So when you're constantly dealing with microaggressions or different things that kind of hit you through the time, you have a lot more cortisol over time, and so then your baseline is just that much more stressed. And when your body is stressed, the responses to health, from my understanding, is just you have much more negative health outcomes. We know that can happen.
Absolutely. Cortisol is a contributor, a very healthy contributor to our fight or flight response. And when the pterodactyl is coming, or the big train is coming at us, wherever we are in the development of we as people, big things happen in our bodies, right? We get prepared to run and run fast. Our pulmonary systems start kicking in. Our ability, I do not look at, but I could probably run fairly fast, or at least for a short distance in an emergency like that, right? I could get out of Dodge. Now, the body is a closed-loop system in some ways. So the way it all of a sudden activates that heart, activates that pulmonary system, activates those fast twitch muscles and the big connective tissue that makes those legs move, it starts taking energy away from other systems, like the immune system. It dampens the immune system. So when you live with chronic stress, that very, very healthy, thank goodness we have it, flight or fight response inhibits our immune system, and it inhibits it permanently. It inhibits it the whole time that we are living with that stress. And now we have a public health emergency with an infectious disease, and we have all of those contributors, and we also have immune systems that don't work as well. So of course people are getting sicker. Of course they are. So now I want to think, all right, this big heavy load, whoa. Especially that last one. Pardon me?
Need to hold it up closer.
Oh, sorry. I have to hold the mic closer, thank you. So now we're going to move into conversation, and we're going to do that both online and in this room. So let's just divide the room into halves. You folks turn around and talk to each other. You folks turn around and talk to each other. And I want you to start coming up with some activities that would be meaningful to address some of this. Near-term activities, longer-term activities. But be specific. What is it? Yes. What is it that we can do individually and as a society, and try to come up with both? Try to come up with some policy solutions, but also try to come up with some things that you as an individual can do, either to contribute to those policy solutions or in your own life. What is it that you can do to start addressing these social drivers of health that show up so immorally in our health?
So I think what might be helpful is we're distributing some Post-its and a pen, and as a group you can write down your action items maybe rather than just shout them out, and then we can talk about them.
Yeah.
And then we have about maybe 10 minutes left.
And
so,
then
yeah.
online, I want folks to chat and come up with some ideas in the chat. Yes.
Well, you can, but
Yeah.
if one person kind of writes things down, that might be a little easier.
Maybe keep some notes
Keep a little
if it makes sense. Yeah. But I want this to be talking. And if anybody needs help moving a chair, okie dokie. All right.
And I can actually just tell
Okay.
you, I can tell you what they said.
You can collect and I'll start reading this stuff.
Okay, great.
Okay, folks, we're going to start gathering back as a group. So you can stay in sitting the way you are.
Perfect.
But let's wrap up the conversations
Any other notepads
and
here?
come back to kind of the large group. So we've started getting some good responses. There's been very lively conversation here in the room at the church. But we also have some good comments that are coming from the chat. And while we are moving ourselves around in the room, I'm going to just start by reporting on what we've been hearing in the chat. So a really insightful observation. Pollution can also lead to disparities. I think about air quality and asthma and what asthma is as a risk for COVID, just as one example. So policies that would address pollution, address food scarcity and food deserts, and affordability of good food, investing in community supports, looking for policy solutions around healthcare, like adopting single payer, mandatory paid time off. I assume that's for sick leave. Supporting healthcare for BIPOC people, bringing healthcare to the community. Very good, feeling safe to going into other low-income areas, increasing income in these areas, so addressing the wealth gaps will help. Individual actions that are coming from within the room, voting, but to know who to vote for, you have to know what the policy issues are. So it connects, so think about the policy issues as you're voting. Identifying resources to help connecting those in need to housing. Commitment of time to help close educational gaps. Maybe commitment of other kinds of expertise. I know we've got a marketing expert in the room. Commitment of somebody who has that kind of expertise to help think about messaging, right? Identifying trusted voices to help carry the message, yes. Let's get away from the health messages only being carried by white men or secondarily white women, and get them carried by people who look like our communities, and not just by government, and not just by healthcare professionals, but also by barbershop owners, and by faith communities, and by other folks in communities. Ask questions of marginalized groups. Who are your trusted partners? How do you want to receive information? Yes, yes. Even if something as formal as focus groups, figure out what people want, right? Action items. Create ways to see institutional racism. Create access and trust in the healthcare system and better communication. All of these wonderful solutions. I've also heard, so we've got about 3 more minutes. I'm going to wrap up here. I'm also going to comment on something I overheard about how paralyzing it is to be thinking about how long it takes to change, right? It just saps your energy. When did these problems first start occurring? We've got dawn of creation in the back. Okay, so they go back to the Adam and Eve story. They go back to slavery. They go back a good long while. Why in the world would we have the hubris to think we can switch it like a switch and think we're just going to achieve, we're just gonna be good liberal people and change it, right? This is entrenched, deep stuff, and it requires long-term commitment. It requires generations of commitment. It also requires immediacy, okay? We have to rescue, but we have to move upstream and change the things that are structurally wrong. And that will take time, and it takes commitment, and it takes energy that we get from each other, because no one person has that energy in them, surely. Every once in a while we meet an amazing person, right? But my goodness, that's why they're amazing. The rest of us have to take a break every now and again and get lifted up by others. Here's another educational thing I'm just going to mention because it was on my mind and we often don't think about it. Education. 1 minute. Do we have any Ivy grads in here? Or do you know any Ivy grads? Ivies are great, big, huge investment banks that happen also to offer fine curriculum. They are massive financial institutions. Alumni impact your school. Say you should be supporting first-generation students more, okay? As one kind of thing. Think outside the box. Think about how you have connections as an alumni. Think about how you have connections as a patient, as a healthcare provider, as a voter, as a churchgoer and member of a faith community. There are so many connections, professional and personal, that we all have. And the challenge is to think about those in these big ways and to just keep it going. So,
Ellie, thank you for your input and perspectives today. Next Sunday, we will welcome Louise Madsen, Executive Director from the Division of Indian Works, speaking on investment in urban Indian well-being. We look forward to seeing you all next Sunday.
thank you.